Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. We are coming to you with the coverage of the COVID crisis from the front lines. We've had conversations with care providers all over the globe who are battling this virus and will continue to share their stories in hopes to provide education and support to all the healthcare workers on the ground. Today, I'm joined by our editor-in-chief, who up until today has been convalescing at his home in London, but went in today the first time to hospital as a critical care physician. Hello, Monty Mythen.
Hey, Desiree. Everyone staying well at your end?
Everyone is doing okay here in the Chappell household. Excellent. Isolating and not playing with neighbors, not doing all those kind of crazy things that are very tough to deal with two little boys, but we're doing okay. How about you? First day in hospital, huh?
Yeah, it was good to go in and to say hi to a bunch of people. Obviously not everyone. It's a very different place to the last time I was in a number of weeks ago. Central London is kind of spooky quiet. That's very weird. Feels a bit like a sort of summer Sunday, that everything's kind of pretty much shut. But I mean, the team in there are just doing a fantastic job. It is undoubtedly overwhelming, but I think they're settling into the new world that they live in now. Yeah, I'm sure. Well, I'm sure we're going to be hearing more from you, Monty, about what it's like there at UCL and in the NHS. But our next guest comes to us from Atlanta, Georgia. She's a critical care clinical specialist at Grady Memorial Hospital, and she's also a frontline provider, Barbara McLean. Thank you so much for taking the time to share your experiences with us today, Barbara.
Thank you so much for inviting me, Desiree, and I'm so happy to share the stage with Dr. Mythen. I've known him for quite a time, and I'm very happy to hear that you're on the mend.
Hey, Barbara, where's the Dr. Mythen thing coming from? Monty, come on.
Monty! Well, that's what I call you personally, of course. So I'm just really glad that you're doing well and coming out the other side of this dark journey, which, as we all know, we can't actually predict what's going to happen once we start it.
Yeah, well, I think I'm one of the lucky ones.
Yes.
Yeah.
There is a lot of unlucky people. I heard our own Prime Minister is very sadly on intensive care at the moment. That's a big shock to all of us. No one can guarantee immunity to this, irrespective of title or status or wealth.
Yes. This is an enemy that doesn't discriminate.
Absolutely.
It pervades every single aspect. And I think one of the big changes for us, and I'm actually on my way into the hospital after we're off the phone, we have a very young woman in her early 20s who is actually deteriorating. So I'll be doing some things with the physician and care team to try to improve her probability for survival. And I think one of the things that we all know is in the very beginning, the discussion was it's such a target for elderly people, and it doesn't mean that we don't have a large target in elderly people. But as we all know, it has progressed to not be discriminating based on age, and not even based on, I forget the term, but just not even humans. Since yesterday, there was a tiger diagnosed with it, or some big cat that has COVID-19. So now we have to worry about our animals as well. And it's pretty hard to isolate your animal because they are not always controllable.
Yeah.
Just like humans.
What do we always say? Herding cats? Anyway, that's what it's like for humans. So we're sometimes worse.
So, Barbara, you're in Atlanta, which is a big metropolitan area, as I recall. If we take New York as a reference point, where are you from the point of view of the tsunami, as we call it?
Well, first of all, I'm in a large urban public academic hospital. We're slated for around 965 beds. We actually had a flood in December, and we lost 250 beds that are now being repaired. And it couldn't be, of course, at a worse time. We are on a steady rise. We have not reached plateau. We have not had rapid rise. And we're predicting that that's going to occur within the next 2 weeks. We have a basic target date, and a lot of what we're doing now is getting ready for that, planning for that, trying to achieve basic supplies for PPE, also advanced supplies beyond what we already have, more ventilators. We already own 70 ventilators that are high-level ventilators and another 50 that are more transport ventilators, but obviously can accommodate, and trying to achieve more ventilators. more cooling blankets, prone pillows, all that kind of supply. But in addition to that, I feel like my administration is very forward-thinking, has been very responsive. I'm running a 24-hour rapid critical care course. It's called Rise Up Critical Care for expert nurses who work in step-down areas or in recovery or in what we call the ECC, which is the emergency room. And those individuals have been selected by their leaders to be persons who will be able to adapt quickly so that we have an increased critical care workforce. We have some rooms where we're cohorting patients. Obviously, like everyone else, we're only at this time cohorting positive patients, not PUIs, and hopefully we'll never have to cohort PUIs, persons under investigation. That means that we think they have COVID, but we're waiting for their test. Sometimes after the test, we still think they have COVID, so then we get a second test. We're really doing the very best we can to prepare for what we believe will be our surge. We are not at the peak. New York is more closely aligned, I believe, to their peak, and we are not at peak time yet. And there are many hospitals in Atlanta, but mine is the public county academic facility.
Barbara, how's the staff holding up? Because one of the challenges and the waves hit them before you, keeping the staff well has been one of the challenges, mixed in with who should you test and the consequences of testing well people who turn out to be positive from the point of view of keeping the manpower.
If I take that into two compartments, one is, do we have a high percent of staff getting ill? And at this time, no. We do have staff who've gotten ill. We have staff that are critically ill, but percentage-wise, for the whole system, the whole hospital, it's a relatively small percent right now. And, that could change. It could change today or tomorrow. That's, of course, the issue. And then the other aspect is, how is the staff holding up emotionally and mentally and physically? So I think one of the most important things that we can talk about is that our patients are relatively high acuity at any time. And I would say significantly higher than most other hospitals actually see. But now our work is 4 to 5 times harder because of doing work in gear, which is, no matter what kind of gear you're using, which is physically challenging. And one of the most physically challenging things I always would like to remind everyone is wearing that N95 mask, which actually is basically encapsulating your breath. Makes it harder for you to breathe, makes it harder for you to regulate your breathing and get rid of your waste products by breathing. And we end up being very, very exhausted just from that. And then on top of it, doing really single person care in general and going in and out of more than one room. So we typically have a 2-to-1 ratio, even though we have very high acuity. And then, of course, looking at the moral and how we feel morally and feeling morally injured, that we have patients who are critically ill and dying in isolation, and of course having an uptick in the amount of deaths that we see in a day or in a week, which is significant. And that all is very, very wearing on our staff, very wearing on our staff, very wearing on me as well. And we've certainly tried to encourage many methodologies. In one of our first patients, I actually, when we were getting ready to prone the patient, we knew that was going to be an arduous process and might actually contribute to the end of life. So we had communication with the family, and we're not allowing any visitors for any COVID-19 patients. We don't allow any visitors, and we have restricted visitation throughout the hospital. We really are just not allowing visitors unless you meet particular criteria, meaning that the patient needs that visitor, and we'll only allow one, and they're screened. But we have adopted a methodology of cell phones and iPads, and we did that very early on. We received some really incredible donations from our community. But the very first patient, my critical care pharmacist said, I have my Grady phone, and it's an iPhone, and the team always calls me on my personal phone, so take my phone. And I took her phone, put it in a biohazard bag, and came in the room, called the family, The patient, of course, was intubated and unconscious. He was paralyzed with sedation and analgesia. Held the phone to his ear so they could speak to him. And that was quite early. That was 2.5 weeks ago. I think now everyone is using other methodologies. And I think that lifted our spirits a little bit to feel that we were able to communicate with families and allow them to communicate, or facilitate their communication with their loved ones.
That is such an important aspect, because I think as a critical care nurse, that's my background. I'm a CRNA and I was a critical care nurse. And I think not having that connection with your patient and your patient's family, especially during those last days of life and when the illness is so critical, I mean, that like impacts you so emotionally and mentally as a provider. I'm so glad that you guys have done that. To hear that other facilities are doing that as well, because that was one of my major concerns when I started hearing some of these reports of people, dying alone and things like that. So that's really great. Barbara, you said a bunch of different things in there, and I want to kind of go back. So first of all, when you were discussing PPE and how difficult it is for providers to work in all the PPE gear, and I know that, we all have been in those situations where we've had to deal with isolation patients, but I think this is kind of taking it to the next level. Can you tell us a little bit about what guidelines that you're following for PPE and how you are supporting your staff and educating your staff when it comes to what's appropriate for the type of patients that you're taking care of?
Yes, I want to just highlight one thing that you said, and that is that it's very difficult for our staff because they are paying such close attention to wearing their apparel. We call that don, that's D with an on, and taking their apparel off, D with an off, and also feeling very tenuous about their apparel. First, of course, because there are some shortages, which we are trying to accommodate. And secondly, being very concerned about the constant validation that what we're doing is correct, and going in the room in their shoes or their scrubs and what that actually means. So that's a significant issue as well. I actually was the clinical lead for the Hazardous Infectious Disease Unit, which is a small area that was developed to accept patients with Ebola viral disease. And I have a small team that's associated with that. And we got 5 patients who were ruled out for Ebola. And I actually physically took care of the first PUI person under investigation, at our hospital. And I asked some other members of that team to assist me because they were so highly trained in PPE. Now, the PPE we're using is very different than what we did with Ebola, but when you have somebody trained at the highest level, it becomes much easier, and plus to work at that at a lower level. And plus, these were people I know and trusted. After that first patient, we recognized that we needed to make sure that all staff were prepared. So along with 3 members of my team, we actually took it upon ourselves, and of course we had the blessing of the administration, but we took it on ourselves to come in at change of shift every day, 7A, we work 12-hour shifts, so 7A and 7P, and train all providers on the floors where patients were being admitted. And in the end, so after we did that for 2.5 weeks, we trained over 1,800 individuals on PPE. Now, we've turned that over to another group. We've turned that over to the big division of education. I don't work for education, I work for critical care. But we turned that over to the education group because we expect that it's going to be massive. And there were just the 4 of us. And 3 are clinical staff members, so they would actually stay after their shift. But because we have a big staff and we have multiple places that are cohorted, it was requiring 4 to 5 hours beyond the regular shift work to train these individuals. But I think I would just say overall, actually taking that at a very early advantage, that taking that role actually has helped to reduce panic and anxiety and fear. Doesn't mean it's not there, but it did help to reduce it. And also trying to assure as best we can that people are donning and doffing appropriately and they're doing it in the right space and they're sanitizing their hands and washing their hands in the order so that anytime they touch anything, they know they must sanitize or wash their hands when they're getting undressed. Anyway, it doesn't matter. You can see when you look at television, I saw the picture of one individual who had their N95 down around their neck. Okay, well, I'm sure somebody trained them, but we don't wear masks under our neck because the masks could be contaminated. Now you're breathing that in. Or people wearing their face shields up or around the back of their head, again, have the possibility of being highly contaminated. So either you have it completely on or you have it completely off. And we have found, we did real time right now. You've got a patient. We're pulling all the staff together. I'm going to dress you. I'm going to undress you. I'm going to dress you again, conserving resources, using only one model and the whole group of individuals. We still find that people have PPE fatigue and they shortcut. Shortcuts cannot be taken. So apart from being physically exhausted, individuals have PPE fatigue. All that getting dressed, undressed, getting dressed, undressed, spending hours, 2 hours, we try to restrict it, but 2 hours in the room, you're very fatigued. And of course, that's the time that mistakes can be made. And what we see it by looking at people on television, that individuals who are doing this frequently, they take shortcuts. But this is not the time for a shortcut. You cannot take a shortcut. And someone needs to be observing you to make sure that you don't violate it.
Yeah. Monty?
So, Barbara, early on, understandably, a lot of our attention was on personal protection. As you said, that's one of the very big challenges we're facing. And then there seemed to be quite a lot of attention paid to the fact that this was primarily presenting as an acute lung injury when it got to the critical care end of things. And mixed in with that, we certainly saw at our end this sort of messaging that crept in again about, run them dry and be careful not to give too much fluid. And we get the impression that a price has been paid with regards to leaving people relatively hypovolemic and possibly dehydrated as well. And now the pendulum is swinging back to say, well, they don't seem to be a classical ARDS. And maybe we should be a bit more liberal and go back to our traditional fluid management practices and just, business as usual. Where are you on that spectrum at the moment in your institution, Barbara? I think I know where you might be personally, but what do you see happening institutionally?
So I appreciate that you know where I am personally, which is I always am very interested in blood flow. So I'm always very interested in blood flow. And in order for you to have appropriate blood flow, you have to have appropriate volume. But as an institution, we are running on the drier side. And I really appreciate what you've said. So as we run on the drier side, what we do have the possibility of experiencing is that we don't have enough arterial blood flow or volume, and that may contribute to the organ dysfunction that we're seeing. But I think it's also very important, and I'm sure we're both as up on the literature as we can be. I haven't had any really time off since February 28th, so I read bits and pieces of literature. But I think one of the things we're seeing is this evolution of the clinical picture with the high ferritin level and the low platelets, which actually tells us that we have some issues with our red blood cells. And for people who are not clinical, the red blood cells are in your blood flow, which is very important. And the red blood cells actually carry oxygen to the tissue and carbon dioxide back to the lungs. And this is an important component of maintaining organ function. So I feel like we don't yet have enough longitudinal data to actually say one thing is more right than the other. I think that most of us are trying to do the best practice based on the most up-to-date information that we have, none of which is going to be an evidence-based criteria because we just don't have enough data yet to make an absolute evidence-based decision. So I would say that the evolution of kidney injury in these patients is so rapid and so high that I think it might be essential to say I want to maintain blood flow. I'm going to keep my patient not dry, but as best I can equivolemic, and hope that that's going to sustain their blood flow dynamic appropriately. But I think that the issue of the early evolution of kidney injury, also what we're seeing, which is nephrotic syndrome, is so high that we also need to be sure we are not just strategizing in simple methodologies, but really trying to understand the actual cellular level of dysfunction that's occurring. I know that Monty knows me well, and he knows I only am pro vasopressors if I can't maintain your blood pressure. I'm much more interested in looking at your ejection volumes, and especially ejection volumes in the artery. But having said that, so you're doing a much earlier intervention for your patients using CPAP and BiPAP. We actually are not that able to control your exhalation with CPAP and BiPAP, so we're not doing that as aggressively or as early as you are. We actually are, we've taken a step back from CPAP and BiPAP, and that will change as we search more, obviously. But I think the other aspect is that we're using very high levels of pressure. So PEEP, we start typically at 14, go up to 22. And what that, of course, does is it obstructs the ejection from the right ventricle. Mm-hmm. And so in addition to saying I don't have adequate volume in my arteries, my systemic arteries, we're also seeing some secondary obstructive shock to the right ventricle. And so that, again, becomes very important because along with our ventilation strategy, we actually are considering something that helps to support the pulmonary vasculature like Velitree and something that may assist the right ventricle. So we might consider milrinone or dobutamine or both together.
Barbara, are you immediately putting these patients that you intubate on these high pressures, high PEEPs? Are they having high pressures and putting them on high PEEPs? And so coming in, they're probably very hypovolemic because they've been sick, and then we're putting them on all this PEEP. Are you doing any kind of initial fluid resuscitation? Because again, I've been getting a ton of questions from colleagues about, whenever you intubate, they're seeing a major drop in blood pressure, and then they throw them on the vent, and then they're just fighting. They're like behind the 8 ball because they feel like they need to run them dry.
So I think we are doing some initial and cautious fluid resuscitation. We are not employing our sepsis criteria. Mm-hmm. Right? We're not doing 30 mLs per kg because of caution about volume resuscitation with this very profound lung injury, which may not be a typical ARDS injury. But we are doing cautious fluid resuscitation, and we're really aware of fluid, and we're trying to maintain, as I said, an equibalance rather than just dehydration. I think overall the message was keep them very dry, and that was what was happening. However, we can look at that subset of patients who evolve and develop organ dysfunction. What we're seeing, again, is acute kidney injury. We see hepatic encephalopathy. We're seeing myocardial dysfunctions, and they're pretty significant. And we see that all in combination. It's like a rapid fast track to septic shock. Yeah. And it happens so fast that we're all working together, and I think we're all communicating around the world, trying to actually develop the best possible strategy.
What types of equipment are you using or techniques to assess? Because are you using TEE? Are you using TTE or point of care ultrasound, advanced hemodynamic monitoring? What are you guys using? Because I'm getting this question quite a bit, how we should monitor our patients in the ICU.
I think you have to monitor with whatever tools you have. And this is not the time to be introducing tools that you're not already an expert with. I think that's most important. We try to limit in and out of our room. However, early and we don't have easy access to TEE or to bioimpedance monitoring. So we early on, typically on our patients, will get an echo, and that will be a transthoracic echo, not a TEE. And then also any patient who is submitted to the ICU gets an A-line and a central line. That's part of our criteria, and that's immediate. And we have methodologies of evaluating the arterial-based cardiac output. Now, many people have many different devices. So it's not about a device, but whatever device you have. So it would be Pico, Litco, it would be FlowTrack that allow you to convert the arterial pulse and the area under the curve into an evaluation of stroke volume. So I'm not interested, particularly here, not interested in the cardiac output because that's heart rate times stroke volume, and most of these patients have a very high heart rate. What I'm really interested in is in their stroke volume. So I say any way that you can really look at stroke volume, whatever tool you're using, and I want to look at LV stroke volume, so it means this is an arterial-based measure, not a pulmonary arterial-based measure, and we're not using a significant amount of PA catheters in these patients. I would say if you believe that based on your ventilatory strategy and your pressures, so if you're using airway pressure release, you're using high frequency oscillation, or you're using high PEEPs or pressure control inverse ratio ventilation, you now need to consider that you may have some right ventricular dysfunction. And the only thing that can really monitor exactly right ventricular dysfunction is a PA catheter. But I want to also remind, in the United States, probably similarly around the world, we have not been using PA catheters as liberally as we once did, which means that people don't have nearly as much experience with them. And now is probably not the time to introduce something of such uncertainty with people who don't have significant experience. So overall, I just talk about a modified Frank-Starling curve with the CVP and the stroke volume. If I give you volume and your stroke volume goes up and your CVP goes up a little and your stroke volume goes up, you're great. If I give you volume and your CVP goes up but your stroke volume does not, I think that then we have to consider that we might have some right ventricular dysfunction. Yeah. And I think those are simple strategies that aren't 100% foolproof, but I think can help us in our quest to do the right thing without using tools that people are inexperienced with.
Yeah, keep it simple. Monty and I have talked about this quite a bit. You know, we don't need to do any fancy ventilatory settings. We don't need to do, be throwing everybody on ECMO or anything. We need to just go back to the basics of good intensive care, treat their ventilator, treat fluids, treat hemodynamics, support those. And so I think it's really back to the basics. So do you have any good resources that are providers who may be still just gearing up to take care of patients or who are just starting to see a little bit of the heat from the COVID surge, that they can get a kind of a back to the basics course, especially for non-critical care providers?
There's a website with a colleague of mine. Her name is Nicole Kupchak, Kupchik. She has 6 20-minute videos on back to the basics with mechanical ventilation. And she covers blood gas, ventilation strategies in COVID-19 and ARDS, prone position, how to do it, when to do it, and why, and rapid intubation criteria. And so that's very nice. So that's Nicole Kupchak, Kupchik. My Rise Up Critical Care course, which I've developed for my hospital, it belongs to me, will be also on YouTube. And free to anybody. It's not for making any money. It's just to help us focus on what the critical care principles are. Now, because mine is a 24-hour critical care course in 30 or 20-minute segments, but it is actually pretty intensive. So it's probably not something that someone who doesn't have any experience with critically ill patients probably will be harder for them. This is designed to take nurses from step down, experienced emergency room nurses, and recovery, we call them PACU, post-anesthesia, nurses who have dealt with critical patients and have some kind of physical expertise in that, but really need to raise their level of understanding and knowledge.
Yeah. Gotcha.
And that'll be available. And if people are interested and they even want to email me, I can send them the links to the components that are already done because I'm ongoing working on it, trying to do it at the same time that I'm clinical. So obviously that means there's limited time for videoing because I'm often clinically at the hospital for 10, 12, 13 hours.
Yeah. Oh my goodness. Lastly, we wanted to ask you, Monty and I have been talking quite a bit about the Nightingale hospitals over in London, and we've seen the mobile or field hospitals going up around the country here in the US. Is there anything like that happening in Atlanta? I mean, Atlanta is a huge, densely populated area.
Yes. Some of the other hospitals in our city actually have a steeper rate of rise than we do. There's been lots of advocacy for field hospitals and methodologies. We have not yet actually converted our convention center. That's called the Mercedes-Benz Convention Center, like they did in New York with the Javits. But again, I think because we are not at plateau, I would say I'm not privileged to know what everybody's agenda is, but I think that's probably in discussion. Now, I think there's discussion about using dormitories and other areas that will actually be easily converted into makeshift hospitals. I was very honored to be asked to edit a 5-chapter manual that came from Wuhan. One of my colleagues, the chief of our lab, is from Wuhan, and he, along with other physicians from Wuhan, developed this 5-chapter manual on how to build a makeshift hospital. It was so amazing just editing it. I mean, I just was editing it and then just contributing to the Don Doff component. I was like, this is so amazing how rapidly they built these incredible makeshift hospitals. So I think that's been released. I can send you a link to that if it's been released. I'm not sure. I haven't heard. But I think it's been released, and it's a great manual on how to build a really effective makeshift hospital. We'll probably never be able in the United States to actually mimic this 100%. Because they have so much control over their population that helps them to make these kinds of things happen. I'd like to just say one other thing, if it's possible.
Yeah, of course.
In my experience, this incredible temperature raise, the level of temperature that these patients present with. So they're oftentimes 39.5, 40, 41 degrees. Part of what I think is very important, I know we talk a lot about not suppressing people's temperature, but in this instant, this is so devastating to the patient, this high temperature. And it's what we call effervescent, which means it might respond to Tylenol, but then once you get to about half-life of your Tylenol or your ibuprofen, what you're seeing is that it effervesces again and again and again. So one of the things that I would recommend considering is early utilization of cooling blankets. And in that very first patient I took care of, because he did not end up intubated, although in retrospect, probably we tried really hard to avoid intubation and he was really young. He was breathing about 40 to 45 times a minute with a temperature that was greater than 39.8, oftentimes greater than 40 degrees Celsius. He just kept saying, "I'm so hot." And so first I asked to put him on a schedule of Tylenol every 6 and ibuprofen every 6. So every 3 hours he was getting medication. But also I just got a blanket roll, a simple cooling blanket, not intensive, and just laid the cooling blanket on top of him, which is not what we usually do. It's usually underneath. I laid it on top of him. And honestly, that actually improved his perspective of how he was doing. And it cooled him so aggressively that he felt better. And as he felt better, I was also able to sit him up, do chest physical therapy, stand him up, move him around. And that high temperature early on, I think, is so debilitating that some of the aspects of things that you can do to try to improve gas exchange, you're not able to do because of the temperature being so debilitating. So I have no science behind it. I know that it's antithetical to what we usually think about controlling people's temperature, but this is not usual. As we all know, this is not normal. And friends that I have, colleagues that I have who've been diagnosed positive, who are home with high temperatures, I actually advocate lukewarm showers every 2 hours.
Oh, yeah, there we go.
To just help release the temperature. And that just improves how they feel and enables them to mobilize, to do whatever it is they need to do, like some people needing to make a will or other kinds of communications. But with that high temperature, you're so debilitated you can't do anything else. Sorry, I just wanted to interject that because I think it's a really important and simple component that people can utilize for their patients.
Well, Barbara, we thank you so much for taking the time. I know that you're extremely busy. Again, like you're taking care of patients in critical care. So thank you to everything you're doing. Thank you for educating the other providers out there. I mean, this is something that we have to continue to update on. As you said, it's a very dynamic process. So thank you again. And, we're going to get through this. So everyone stay safe, stay well, and thank you.
Yeah, look after yourself, Barbara. Stay strong. They need you.
Yes, thank you. I'm at risk because I'm 68, but it is for all of us a big adjustment in whatever we're adjusting. So thank you very much, and thank you to all of the healthcare providers out there. Monty, please, you take care of yourself and take lukewarm showers if you have a temperature.
Well, I was going to say he probably was. He did have it. He was febrile for.
That's normal in London. We can't get the
Yes. Get hot water.
It's the best we can do.
That's right, because there's so much humidity. You're always having showers.
Exactly.
I got you.
Good.
Well, it's really great to see you. Continue to take care of yourself. I know you're back at work, so keep yourself safe. We assume you have some antibody, but we don't really know. So we don't know anything.
Soon.
Yeah, find out soon. Same.
Top Med Talk.
Thank you for listening to Top Med Talk. You can always find us on Twitter, LinkedIn, Facebook, and on topmedtalk.com. We want everyone to stay safe. If you have any questions or you want to talk to us on Top Med Talk, please reach out via contact@topmedtalk.com. That's contact@topmedtalk. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Lifesciences, for their generous support through this global crisis.